institution and the work that Cinnamon's been doing with her organization, and how, because we just sit at home and talk about the things that we're passionate about, how those have crossed over into the cancer field, and some future work that we're going to be doing collectively. So the title of the talk is Indigenous Perspectives on Cancer Treatment and Caregiving. My portion is going to be more on that treatment end, so access to care, clinical trials, collaborative research projects with tribes. Cinnamon's going to talk about her work after me, and talk about a caregiving perspective, and how that has informed some of the work that she's been doing. So, this didn't move. There we go. Okay. So like I said, I'm in the Division of Oncological Sciences. I'm also the pharmacy lead for the Northwest NACOE, Northwest Native American Center of Excellence. So I'm leading our pharmacy program there. And I'm faculty in the Brendan Colson Center for Pancreatic Care. And most of my research revolves around pancreatic cancer, specifically pancreatic adenocarcinomas, access to care for tribal communities, and how can we bridge those gaps to make sure that our people who are living on the res have access to the highest quality cancer care. This is our funding sources. Today we're going to be talking about land and culture, why that's important when we're treating patients, PDAC, pancreatic adenocarcinomas. We're going to talk about tribal sovereignty and data sovereignty in tribes. And then I'm just going to go over some of the projects that we have actively going at OHSU. So, I'm Lakota. I'm in Lakota. I grew up on the Pine Ridge Reservation. So this is a res that's on the southwest part of South Dakota. And specifically, I grew up in the Porcupine district, right here where that circle is. So when someone asks me where I'm from, I say South Dakota. They're native, I'm gonna say Pine Ridge. If they're Lakota, then I'm gonna say I grew up in the Porcupine district. And I think that's important because our people are land-based. Our medicines and our teachings come from the land, which is unique. So when I think about where I'm from here, from this picture. So I grew up kind of like straight right in the middle of the picture towards those hills back there. And when I look at this picture, I can smell the grass, I can feel the wind. I can feel those grasshoppers like jumping on my bare legs and scaring me. But this is the first dirt that I touched when I was a baby. This is the first air that I breathed. This is the first place that I had ceremony. And it's an important place. It's an important healing place for me. And I think all of us who are in this room and listening, who are Indigenous people, have places like this that are healing places for them. Something that's unique about being a Native person is that our sacred places are land-based. So this is a picture of our family at Wind Cave in the Black Hills. And if you know the Lakota creation story, this is where we come from. And if you're sitting in our car with us on a long 7-hour road trip, you probably heard this story, so only my kids and my wife. But this version of the story, all of our families have different versions, but back in the day, before the earth was ready for us to inhabit, we lived down under the Black Hills in caves. And we were waiting there for the earth to be ready for us to come out, waiting for Tunkashila to tell us that the earth is ready for us to come out. We have a trickster, like all of our tribes do. We have a trickster named Iktomi, and he was banished from the spirit world with all the other spirits, and he was sent to earth. And because he was playing all these tricks, and he was on earth and he was bored and he needed someone to play tricks on, and he knew the Lakota Oyate, the Lakota people were down there in that cave. And he was like, how do I get to them? How do I get them out here so I can play tricks on them? So he recruited Shubmani Tutanka, which is wolf. And he took Shubmani Tutanka and he loaded him up. This is the version I tell my kids. He loaded him up with this backpack with all the best things you could think of. So PlayStation 5, Little Caesar's cheesy bread with the buffalo sauce, root beer and sour gummy worms. And he loaded that wolf up and he said, go down there and show those people all the stuff that's up here on the earth. None of that stuff was up there, obviously. We sent the wolf down there and that wolf went down into Wind Cave. And at this time, Wind Cave was a huge opening, like as big as this room. You could just walk in. And he went down into that cave and he went all the way down until he found the Lakota people down there. And he came up to them and he said, look at all this stuff we have up on the surface of the earth. You could come play Fortnite and eat pizza and it's going to be great. And those people down there, they took the food and they took the video games and they played them and it was awesome. They're like, oh man, why are we in this cave? Let's go up to the surface of the earth. If all this is up there. And there was two warriors down there. One was Tokahe and the other one was Tatanka. And they talked and Tokahe said, we should go up there. Look at all this cheesy bread we could eat. Let's go. And half the people agreed with him, but the other half, they agreed with Tatanka. Tatanka said, no, Tukashila said the Earth's not ready for us. We need to wait until Tukashila tells us it's okay to go. So our people split into two. Half of our people left, went up onto the earth, came out of that wind cave, walked out with Tokahe. The sun hit them and it was warm and it was nice. They smelled that sweet grass. They could smell the sage. They could hear the water running and it was really, really nice in August in South Dakota. But then by the time September in South Dakota comes around, in October, it gets really cold and there's no food. And the people started to starve and started to die. They didn't have any shelter. And they prayed, Tukashila, come save us. We're out here, we're dying. We need you to come save us. Tukashila didn't hear the prayers, but Tatanka did. And he prayed to Tukashila and he said, my people are dying. Turn me into a big shaggy beast so I can give myself to them. And he did. Tukashila turned Tatanka and the other people into the Tatanka Oyate, the Buffalo Nation. And all those buffalo came out of this wind cave and they gave themselves to our people as the first food. So that happened here. And after those buffalo came out, that cave shrunk. It's like this big now. You go walk up to it, you can feel the wind coming out of that cave. And that's the breath of the buffalo that are still in there. And this is a sacred place for us. And if you look at this picture of our family, you'll see all these prayer ties because we go there to pray. This is a sacred place of healing for us. I live in Portland now. It's really hard for me to access these places. And even people living in South Dakota have trouble accessing these places from our reservation. You have to leave the res and you have to go there. These are healing places that have different types of medicine that our people deserve to be around, especially when they have cancer and they're going through that journey. So this has informed my research in how do we provide systems in these academic hospitals and these institutions that support this type of prayer, this type of healing, at the same time as granting access to phase 1 clinical trials, surgeons who are experts in the field, like groundbreaking studies. Our people deserve those things too. So we need to adjust our systems so that a patient coming from the res doesn't have to make the choice of, do I leave the res to get this treatment for months and months and come back, or do I stay and maintain my connection to culture, maintain my connection to these prayer places and families, and just take a palliative care approach to treatment. That's important. Everything I just said was supposed to be this slide, but our stories and our medicine live on these lands, and how do we maintain those connections? I want to talk quickly about pancreatic cancer because that's where my research is focused. We are broadening out to include all malignancies. So I'm a Pharm.D by training, an oncology pharmacist, and I work in GI oncology. In my residency, I did research in neoadjuvant chemotherapy and chemorads prior to Whipple procedures for patients. So comparing different treatment modalities, neoadjuvant chemo plus or minus chemo and radiation prior to a Whipple procedure for patients who are resectable or borderline resectable pancreatic cancer patients. And that's what I focused on in residency. And then I took a job at OHSU and I was like, all right, I'm just gonna be a clinic pharmacist. I want to focus on patient experience. That lasted for about 1.5 years the Brennan Colson Center found me and brought me into their research team, and I've been working with them ever since then. But pancreatic cancer is the 10th most common cancer. It's the 3rd leading cause of cancer-related death, soon to be the 2nd. So every year there's about 60,000 cases of pancreatic cancer in the country, 50,000 deaths. The average life expectancy for someone diagnosed with pancreatic cancer is about 13 months. In our communities in Oregon, the rate of pancreatic cancer is almost twice the rate of the general population in Oregon. And we don't know why. So there's not a lot of studies that are looking at this in our patient population. It could be these modifiable risk factors that we have higher rates of, type 2 diabetes, obesity, tobacco use, or it could be something else. We just don't know because we haven't had any focused attention in that area. So I talked about the life expectancy of this disease, but I want to talk about why it's so deadly and why it's important that if you are diagnosed with pancreatic cancer, that you are seen at an academic medical center that specializes in pancreatic cancer. So symptoms are very general. If you eat my son's diet of Little Caesars pizza and root beer, you'll probably have all these symptoms, maybe not the weight loss, but the pain, anorexia, nausea, diarrhea, vomiting. And this is just general abdominal symptoms, you know, nothing pointing that something's serious. And once that pain does get to the point where something's serious or it is found incidentally on other imaging exams, most of those patients that are then diagnosed, 80%, are not surgical candidates. So when we think about cancers in general, solid tumor malignancies, we think about staging those. Stage 1, 2, 3, 4 is metastatic. For pancreatic cancer, it's staged differently. It's staged based on how resectable it is, because the only curative treatment for pancreatic cancer is a resection called a Whipple procedure. And 80% of patients at diagnosis, at the time they find out they have cancer, are not eligible for a Whipple procedure. So the majority of patients, we're telling them, we can give you chemo and extend your life, we can give you palliative treatment, but unfortunately at this, we don't have an option that's gonna cure you or put this disease in remission. There is a small section of patients, 15 to 20%, who are either resectable, borderline resectable, or locally advanced. So those are the patients, that group of 3 patients, 3 groups of patients are the ones we're thinking about taking to resection for a curative treatment. Resectable patients, we can take them right into surgery right away, cut it out. Borderline resectable patients, because where the pancreas is located around the stomach, the gallbladder, the duodenum, the superior mesenteric vein arteries, that vasculature that feeds the pancreas, those borderline resectable patients, unless we shrink the tumor, we can't take them to surgery. So those are the ones that we give chemotherapy to first, and I did my original studies in. And then locally advanced disease. These are patients that, and these are defined in the National Comprehensive Cancer Network guidelines as patients who have involvement of their vasculature more than 50 degrees around any one of those arteries or veins. So if it's more than 50 degrees around, those patients are locally advanced because the disease hasn't spread outside the pancreas, but unresectable because it's too involved with that vasculature to take out. That's the definition in the NCCN guidelines. What we know is that with neoadjuvant chemotherapy and with a skilled enough surgeon, there is a portion of those patients that we can give a Whipple procedure to. But you need, the key to that is a skilled surgeon, a surgeon who does these procedures all the time. And you will not find that type of surgeon at a general hospital, as a general practice. You need someone who specializes in. And what we mean by specialize is someone who does the procedure every week, multiple times a week, all year, because they have the best outcomes for that procedure. And that's important because if you do not remove all of the tumor from the pancreas, even if you have a little bit of residual disease left, and you want an R0 resection, means there's some healthy tissue between what you resected and what is remaining. If you do not get an R0 resection, those patients have the same life expectancy as if they had never had that surgery at all. You might as well not even have brought them in there because we didn't get all the tumor out. Same life expectancy is going to be about a year and a half for those patients as well. But now they lost half their pancreas, they lost half their stomach, they lost their duodenum, they lost their gallbladder. They have to be on amylase and lipase. They're diabetic now, and we really decreased their quality of life. So again, the skilled surgeon who can make a good decision about what they can and cannot resect is so important in these patients. Like I said, there's higher incidence of pancreatic cancer in Native populations than US white population. We have the worst survival of all ethnic groups. In Oregon, we have twice the incidence rate of pancreatic cancer. We tend to present at later stage. And we have higher rates of those modifiable risk factors. At OHSU, our #1 accruing clinical trials in our cancer center are pancreatic cancer clinical trials. And in the first 5 years that I was there, we enrolled 0 tribal members in our clinical trials for pancreatic cancer. So we have this low clinical trial enrollment. So what's causing this? A huge barrier to overcome is that our communities are largely rural. We live in rural communities, and access to care is hard for us. When you have to travel in Oregon, from our closest reservation, Warm Springs, you have to travel over a literal volcano. And in the wintertime, there's feet and feet of snow to get over that. Because of that, we have patients who have late detection. Our shared historical traumas inform the way that we view the healthcare system and affect the way we interact with the healthcare system, which leads to this lack of trust. Lack of trust leads to lack of research, because if a Native patient doesn't trust the healthcare system, they're definitely not going to enroll in a clinical trial. And then contributing to that is a misunderstanding or even a complete lack of knowledge of tribal sovereignty and data sovereignty, and how that impacts clinical trial enrollment. So let's talk a little bit about access to care. I spent 2 years at Indian Health Service, and I always feel like self-conscious because we work so hard at Indian Health Service. And this isn't about those of us and those who are there right now working. It's just that we're underfunded. You know, when you compare the funding for the average patient at Indian Health Service, it's about $3,000. Compare that funding to the VA, where it's about $8,000. And I don't think any of us would sit here and say the VA is fully well-funded. And even in comparison, we are so much more underfunded. About 41% under budget and 25% understaffed. You can go to any of the IHS clinics and look for job openings, and you're just going to see like pages of job openings. 68% of our people live on or near tribal lands. So again, rural lands affecting access to care. A third of our people live in poverty. And a lot of the states with the highest number of Native Americans do not have a pancreatic cancer specialist center there. So an NCI designated pancreatic cancer center, including Montana, including my home state, South Dakota, which really impacts where you can go get a Whipple procedure done by a specialist. Let's talk about historical traumas. I took these slides out because I'm speaking at NACOE, but I also wanted to include them for those listening who are not Native. So I think all of us Native people hold this knowledge. We learned it as kids, and it informs the way we look at life, and we look at the way we interact with the world. So some shared historical traumas, starvation tactics by the U.S. Cavalry, U.S. government. I just talked about how Tatanka Oyate were given to us as our first food, and because they were so important to Plains Indians, the U.S. government hunted them almost to extinction to starve us. There were also policies in place that allow for the enslavement of tribal members, and in some cases in California, the legalized killing of tribal members by California militias so that they could get to gold, the land that had gold. Indian Removal Act, the Trail of Tears, Moral Land Grant College Act. I'll talk about more. Indian Relocation Act. A lot of our grandparents went through this, where they're moved from the res to larger cities with the promise that they'd be trained and they'd have jobs, which for a lot of people didn't come through. Forced sterilization. There was a point where in the 70s where a quarter of our women were sterilized without their knowledge by Indian Health Service. The American Indian Religious Freedom Act. My generation is the first generation that has lived their whole life where all of our ceremonies have been legal in the United States. Up until that point, Sundance was illegal. And then obviously missing and murdered Indigenous women are murdered at 10 times the rate of the average women in the United States. All these things are in our mind constantly. Maybe they're not like formed thoughts, but they are back there, and we know that these are histories that we carry. So the Moral Land Grant Act, this was an act that was passed to utilize unused tribal lands that we agreed to being tribal lands through treaties were not being used the way that the government wanted or thought was the right way to use them. So the government took a lot of those lands back, sold them to private companies, private people, families, and they took that money and they used them to create the endowments for universities. So Montana State, our sister university in Oregon, Oregon State University, where our College of Pharmacy was at, it's now on our campus, but all land grant colleges that had their endowments from stolen Indian land. The other thing about this that I always think about is a lot of these universities have these academic medical centers attached to them with these clinical trials, with this really high quality of care, and it's hard for us to access. And that was built off of our stolen land. Not everything's built off of our stolen land, obviously, but that specifically like double, you know. Indian boarding school systems. So Captain Pratt, he was with the US military, and then they put him in charge of our kids to develop these boarding schools. And his approach was to kill the Indian and save the man, cut our hair, stop us from speaking our languages, stop us from practicing our ceremonies. Thousands of kids were taken from their homes and never seen again. And now we're finding through like imaging of the land that these schools are on, that there's actually graves of kids there that were not disclosed. So this red circle is on my dad. You can tell he's my dad because he's got the same ears as me. But he went through one of these schools as well. And all of this is in the back of our minds and leads to a lack of trust with the healthcare system. You think about going to an IHS clinic, you walk in and you're seeing people in military uniforms who are supposed to help you with your medical issues. Same types of military uniforms that were used to oppress us and put us on reservations and take our kids. So of course that affects the way that we view the healthcare system. And there was a survey done at Monument Health in Rapid City, which is a regional cancer center that serves a lot of my tribe. And this survey was looking at attitudes and views of the cancer care. And what they found is that being Native American is independently predictive of having a higher mistrust of the healthcare system and lower satisfaction scores, regardless of anything else, just being Native. They also found that Native people were more likely to agree with the following three statements. In the past, clinics and hospitals have done harmful things to patients without their knowledge. I worry that doctors and nurses will do experimental studies on me without telling or asking me. I have put off getting medical care in the past because I felt that I would be treated disrespectfully. And I think in my life, I've seen this play out with people in my family, with my extended family, and how they view the healthcare system and how they avoid the healthcare system. So how can we overcome these? Now we're going to get into the positive stuff. At our NACOE, Northwest Native American Center of Excellence, we have quite a few pathways to overcome. One part of this is increasing the number of Native Americans in the healthcare system, so that when a Native person goes into the clinic, they are encountering someone who looks familiar, someone who has a shared culture with them, who can understand their perspectives. So we have quite a few different programs within our NACOE for high schoolers, tribal health scholars, for undergrad students interested in the medical field, the Tillicum Summer Health Experience. And then we have our pathways into the professional degrees, Weiss medicine, dentistry, and then the nursing, and then the one I'm working on, Weiss pharmacy. So our Weiss pharmacy program uses an early assurance program for undergrad students. If they complete the pharmacy early assurance program, which is completing all the prerequisites with a certain grade point average, having shadowing experience, and doing research with one of our researchers, they automatically get a position in the College of Pharmacy. And we're hoping to do this because we need to increase research in our communities. And I believe that Native people need to be guiding and leading that research. Doesn't necessarily mean they need to be the PIs on the research, but they need to be heavily involved in the research. And their views need to be taken into consideration. Because a lot of times we're left out. And we make up a very small small portion of the population, about 2%. But even in these large cohorts that look longitudinally about risk factors for cancer, we're not even pulled out in the statistics. There's no genetic studies looking at pancreatic cancer and why we have higher rates, and there's no behavioral and comorbidity related risk factor studies. So this is where my focus has been in my research. And I've always approached all of this work with tribes with, first and foremost, recognizing tribal sovereignty and data sovereignty, and that even though I'm a tribal member, I'm not a member of these tribes that I'm working with in the Northwest, and this information belongs to them and can only be shared by them, and it can only be given to us by them with their full consent. An example of how, there's so many examples of how this has been stepped around and misused, but a recent example is in the COVID-19 pandemic. The Seneca Nation, because they wanted to protect their people, they did COVID-19 screening clinics on their reservations, and they hired an outside organization to come in and do those screenings. What they found out later, after that organization left, was that that private company was doing cheek swabs on their tribal members. They were consenting individual tribal members, cheek swabbing them, collecting genomic data, and we have no idea where it's at. But they didn't go through tribal IRB. They didn't go through the sister IRB at any of the hospitals that are associated with the tribes that share IRBs with them. They just did it. And the tribe didn't find out till later, till all of this information was already gone. It was already collected and in the hands of this private organization. So how are we overcoming these barriers? Like I said, I'm from Pine Ridge. I grew up in South Dakota. I don't know what it's like to grow up in Umatilla or Orange Springs or Chiloquin or Grand Ronde or these reservations in Oregon. So I'm coming in as a guest there and trying to build community and trying to build trust with the tribal members because I have research ideas, but that doesn't mean that they're good ideas for those tribes. And that's why we need collaboration and we need open communication with the tribes so that they can inform our research and drive our research and be the ones who come up with the ideas. And we are just tools that implement those ideas for the tribe. So these are the current projects that we have in place in Oregon. So tribal liaisons, our community building events, provider education, tracks, which I'll get into more, providing data analysis for the tribes with our statisticians, entering into data use agreements that uphold tribal sovereignty, patient navigation, and then our pancreatic cancer high-risk clinics. And one that I don't have on here, but I do talk about later, is also environmental health. So these are the 9 tribes in Oregon. We are currently working with 5 of the tribes. So the one in the middle is Warm Springs. That's the one that has to drive over the volcano. Then we have Grand Ronde up in the northwest, Umatilla in the northeast, and then down south we have Burns, Paiute, and then the Klamath tribes. And these are tribes that we've engaged with, and we've started to build pathways to increase access to cancer care for their tribal members. Our team started out really small. It was 3 people, myself, Dr. Brody, who runs the Brody lab at OHSU, and Dr. Shannon. And we got initial pilot funding for this work, and our team rapidly expanded. This isn't even our whole team yet. There's about 16 people who have a good portion of their FTE dedicated to working with tribes from the Knight Cancer Institute, and work together. I did want to also point out Dr. Amanda Briegel here, who's an oncologist, gynonc oncologist, and we work closely together on these projects as we're the only 2 Native faculty in the Cancer Center. So step 1, when we're engaging with tribes, again, I don't know these communities. We need someone to help us engage with the community. We hired tribal liaisons. Lonnie James is our tribal member from the Warm Springs Reservation, Linda Crocker Daniels from the Klamath tribes in Chilliquin. And we hired them to introduce us to the processes of the tribal governments, to inform us about how to engage properly with the tribes, to be there in every meeting and make sure that we are upholding the needs and the desires of the tribe. And when we go into all these communities, the first thing we do is we try to hire a full-time tribal liaison who works there, who lives in the community, works there, and can represent us. One of the first things that our tribal liaisons do when we go to the community is they set up these community events, dinners, basically listening circles. We hire a tribal member from the community to make dinner, and we sit and we talk about cancer, because a lot of people have a lot of questions about cancer. So we bring lab researchers. Well, I go to all of these events. We bring oncologists, and we just talk about cancer, and we listen to the community talk about cancer, and we have discussions and we learn, and it leads us into the projects that we propose and we develop together. We also table at health fairs, powwows. We do lunch and learns for the clinics. The clinics will give us a subject, and then I'll ask some of my colleagues if they'll come to the res with me and present on that. We also present to Tribal Council and the Joint Health Commission. Because ball is life, we host the 3-on-3 tournament. Going back to our Indian boarding schools, which were just a terrible point in our history. One good thing that I can say that came out of it is in those Indian boarding schools, they introduced basketball to us. And they thought it was going to show us discipline. And they thought it was going to make us listen to the coaches and do all this. Instead, we turned it into res ball, which is running gun and shoot case. But that's been all, as I've traveled and gone to different reses, everyone loves basketball. And so we've used that. We held a 3-on-3 tournament last summer. We're going to hold it again this summer. And we use that 3-on-3 tournament as a place to bring the community together around basketball. And in between games, we teach them about cancer. We teach them about screening. We make sure they're up to date on their HPV vaccines. We trap them with basketball and educate them on cancer. Recently, we hired Tori Eaglestaff, who is our statewide tribal research liaison. She was with the Northwest Portland Area Indian Health Board and led their cancer coalition. And we're so fortunate to be able to hire her to lead out all of our research projects. She's our project manager. Her new designation is going to be FIRE, F-I-R-E, the facilitator of Indigenous research and engagement. And she is our tribally facing person for the Cancer Center. If any of the tribes want to work with us, they can reach out to Tori, and she can put them in contact with who they need to be in contact with. She also leads our tracks, our tribal research advisory committees. So when we go into the community, the second thing we do after we hire a tribal liaison is recruit for these paid positions in these research advisory committees. These research advisory committees help us collaborate on projects with the tribe and create projects that are beneficial to the tribe and create pathways for other researchers to come in and have their projects reviewed by the tribe and receive direct feedback from the tribe. The tracks use a system called ROCKERS, the Research and Organ Review System, that we used in other rural non-tribal communities first to increase research engagement. This has been adapted to our tribes, and it's a bi-directional model for research. We can introduce our research projects to the tribe through the track, through the ROCKERS system. The tribe itself can introduce their research projects through the track, through the ROCKERS system, and together we can work together to create a project that again benefits the tribe. So making sure that these are things that the tribe actually wants to engage with. During these first 4 track meetings, they're 90-minute meetings. We pay participants $50 to $100 a meeting for the first 4 meetings. And in those meetings, all they're creating is something called a cultural landscape. And this uses the C-PESTLE model. So looks at cancer, political, economic, social, technological, legal, and environmental aspects of their community. So they create a document that has all of the information that the tribe thinks is most important for an outside researcher to know about their community. And these documents are different for each tribe because they get to create what that document looks like. And so that's the first task that they do as a track. Once that is completed, then we implement the ROCKERS process, which is this review system for research proposals. So the first step in the ROCKERS process is me or you as a researcher has a research project that they want to engage with the tribe. They go to the track. They tell them that they have this research project. They present it to the track at a track meeting. The track has a scoring system that they've developed based on that cultural landscape that scores each thing that they said was important for their tribe, scores that project based on that cultural landscape. They then give that feedback back to the researcher in the form of a stoplight. So a green light is, this is a great project. We endorse it. We want you to roll this out in our community. A yellow light is, you're close, but you need to make some adjustments before we would consider again, and you would have to go back through the ROCKERS process. And a red light is, doesn't matter what you do with this project, we aren't ready for it, we don't want it, sorry. So this is what we implement with the tribes as a review system. So after we implemented this review system, we took proposed projects through that review system. One of the questions that kept coming up when we would go out into the districts and into the communities and have these conversations is, what kind of cancers are we getting? And we don't know. We have state level data, county level data, but that isn't tribally specific. So we could give them some ideas, but the questions that kept coming up is, what cancers are we getting? How, what's happening in our community? And so we partnered with our first project to just get accurate cancer data for the tribes. So partnering with the state, partnering with Indian Health Service, partnering with the tribal clinics to get that accurate cancer data, giving it to our statisticians to interpret, and then presenting it back to the tribe, not publishing it or sharing it anywhere else, just presenting it back to the tribe. The second project was creating these Indigenous community oncology navigators, icons, because patients who were diagnosed with cancer in the communities were having a really hard time getting to OHSU because it's just so impossible to get a quick visit with an oncologist. So we have these icons, well, one icon right now, and she works with the tribal clinics. When there's a new diagnosis, they can reach out to her directly. She knows all of the clinic schedulers and nurse coordinators, and she can just call them, Teams them, send them an email and say, can you get this patient in quickly? And that's how we bypass the bureaucracy of going through a big hospital to get a patient seen quickly. So otherwise, if you have a new diagnosis of cancer, sometimes you just don't care where you're seen. You just want someone to look at it and tell you what's going on. And that's where our patients were not coming to OHSU for pancreatic cancer. They're going out into the community, and not having an option for those to be seen by those surgeons that are specialists. I didn't mention this before, I don't think, but so where you see an increase in outcomes for a Whipple procedure is if a surgeon does 15 Whipple procedures in a year. So if a surgeon does 15 Whipple's procedures in a year, the overall survival for those patients goes up by about 60%. 5-year overall survival goes up to about 60%. If they see less than 15%, 5-year overall survival is between 10 and 20%. So there's a huge jump there in overall survival if you have someone who's a specialist in this surgery. Our surgeons, we have 3 surgeons who do over 100 Whipple procedures a year. So it's very specialized they are. So how do we identify these patients who are at higher risk? We need to identify them earlier when they are surgical candidates. So we need high-risk pancreatic cancer clinics. And then finally, like I said, this is a bi-directional model, and the tribe, Warm Springs tribe, is concerned about their water source and their salmon. And because of that, we have also started a environmental health project looking at their water sources and contamination. So data use agreements, we work closely with Dr. Rodney Herring, who's the director of the Department of Indigenous Cancer Health at Roswell Park in New York, who told me the story about the Seneca Nation and the COVID-19, and he actually wrote an article about it. And he's worked with us to adapt their data use agreements to fit our tribes. We've worked with our data science officer, Shannon McQueenie, on creating these, and she's really been an advocate towards OHSU's legal team to say that you don't own this data, you can't decide what happens with this all belongs to the tribe. And that was a battle that she took on and she won for us, which is really huge. Again, the tribe is just asking us what is going on with cancer in our communities, and that's where we use this first data use agreement to analyze the data in the tribe and find out that pancreatic cancer was actually happening at twice the rate than the rest of the state, and started to inform these projects into pancreatic cancer. We hired our Indigenous Community Oncology Navigator, Pearl Rose, who's Fort Peck. This year we had 3 confirmed cases of pancreatic cancer in Warm Springs, which is a community of less than 3,000 people. And if you can do the quick stats, it should be like 1 every couple of years that we're seeing, we are consistently seeing new diagnoses there throughout the year. When I made these slides last week, this said 0 referred to OHSU, but as of this last week, we had 1 patient. I texted him last night and asked him if I could talk about him. Lonnie McEwen, Warm Springs tribal member, diagnosed with pancreatic cancer in the community. When he was diagnosed, the inpatient doc told him he had 3 months to live. He was referred over to OHSU. Our oncologist saw him, our surgeon saw him, and they told him that he has a rare form of pancreatic cancer called acinar cell pancreatic cancer, and it's slow growing, and he's probably going to live for, I don't know, a decade maybe. But really, really just a great story. And yeah, he's just such a good guy, and I'm so thankful that we were able to get him in. And Pearl has been instrumental in that, coordinating all of his care. Now, our high-risk pancreatic cancer clinic, Dr. Shepard is the director of the Brennan Colson Center for Pancreatic Care, and he's been a real champion for this work. He himself has a high-risk pancreatic cancer clinic in Portland, where he recruits patients. I asked him if he would be willing to have that high-risk clinic travel to Warm Springs, 2 hours away. He said yes. So we're developing this high-risk clinic. We're going to identify patients based on, with the clinic staff, so newly diagnosed type 2 diabetes patients over the age of 50 without other risk factors. That's a sign that there's some sort of inflammatory process going on in the pancreas. We're going to identify patients in person via surveys for risk factors and family histories. And then we're also going to adapt a larger statewide project called the Healthy Oregon Project, which is an app-based screening tool for all cancers, but we're just going to use it for pancreatic cancer here to identify those patients at higher risk of developing pancreatic cancer. And we're going to give them the opportunity to be enrolled in this high-risk clinic where they would get imaging on a yearly basis, so that we can diagnose them right away and they would have a chance to receive a Whipple procedure. Our tribally led project, this was like day one when we walked into Warm Springs. The elders said the salmon looked different. The salmon's their first food. Our first food is buffalo. Their version is salmon. And they had the salmon runs and they would cut the salmon open and they would say it looked different. The salmon, the meat was a different color. The salmon looked different than they did when they were kids, and something's going on. And they said, that's why we're getting sick so much. So they led this project that resulted in us finding funding for research into water contamination. And what we'll be doing is we'll be testing the river that goes through the reservation and the wells from the different districts for heavy metals that we think could be contaminating the water. We also have partnered with Dr. Brody's lab, who has aged mice models. So we will use those ratios of heavy metals in these aged mice models to see if we see an increased rate of pancreatic cancer in those patients. So those will be aged models, as well as like hyperglycemic models, mice models. And then we can present that information back to the tribe. So future direction, we want all of this, we want this collaboration in all 9 tribes in Oregon. We want to include all malignancies so that anyone diagnosed on any res in Oregon has the chance to at least get a second opinion at OHSU, or we can even help coordinate care at a local hospital when appropriate. A part of this is making it easier to stay in the community. So bringing the high-risk clinic to them. Our patient navigator, Pearl, coordinates visits locally, lab visits, imaging, all those things, so patients don't have to leave the res and come see us for those. And then our providers will do virtual visits when possible. And we've even had, not for pancreatic cancer, but we had a tribal member who had hepatocellular carcinoma who didn't meet her surgeon until the day she walked in for surgery, because we had coordinated all of her care locally until it was absolutely necessary that she came in for that surgery. Something that I'm really excited about, again, because ball is life, Northwest Nations Invitational. I recently was named a fellow for the Cooney Foundation, which came with some unrestricted funds. And of course, I'm going to host a basketball tournament about cancer with those unrestricted funds. So I'm recruiting, our team is recruiting all the high schools in the Northwest, kind of like the Lakota Nation Invitational in South Dakota, which my dad started. We're recreating that in the Northwest to get those tribal communities to gather again around basketball. And when they're there, we're going to screen them for cancer. We're going to give them HPV vaccines. We're going to educate them on healthy lifestyles. We're going to host statewide track meetings. And we're going to present on the state of cancer in the Northwest. Finally, all of this, we want to lead into creating an Indigenous cancer center at OHSU. We've been doing this in the background by hiring all these natives with our grants and keeping them on. But now we're trying to make it official, and that's the goal. So this is my dad, Chuck Cooney. There's a Cheyenne teaching that says you're not dead until your name's not spoken. So sorry. Today is March 12th, which is the day he died. But this is where the overlap happens with cinnamon, and the work that we've been doing together. I can't look at her. And my dad, he was drafted. He went to Vietnam, and when he was out there, he said that they would fly overhead and just drop Agent Orange on him, and they'd be going through the jungle, and he'd have his canteen, and he'd put it under the water. Agent Orange would be like floating on top. He'd put it under, fill his canteen with water, and that's what he drank. And he ended up getting cancer later and dying while we were living on the reservation. And it was really hard for us to access specialized care because he had a leiomyosarcoma, a very rare malignancy. You need to see a specialist if you have a leiomyosarcoma. And again, Pine Ridge does not have a leiomyosarcoma specialist. They don't have a sarcoma specialist. We had to travel to the University of Colorado. And we were able to do that because my mom was a teacher on the res, my dad was a teacher on the res, so we were pretty well off in that respect, and we were able to coordinate it. But it's not as easy for other people. And that's why we need these systems in place. A teaching that I got while working in Warm Springs from an elder was this. The swimmers are the caretakers of the water. The winged are the caretakers of the air. The four-legged are the caretakers of the land. And we are the caretakers of the caretakers. Sorry, I've talked about my dad in so many lectures that I've never cried, but yeah. So I just want to take this opportunity to open the floor up for any questions. And then after that, we'll transition to Cinnamon's portion, and she's going to get into the details about how we've collaborated with the work that she's established with our cancer patients. So I'd be happy to answer any questions.
Thank you for your talk, and it seems like you built such a wonderful group and really expanded it. And I just wanted to ask you, like, oh my God, here, how did you find champions amongst your administration to be so supportive to build such a huge, like, conglomeration? Because I feel like that's often what you need is you need to get institutional investment, and it starts with your administrators. So can you talk a little bit about like what those conversations were like?
I am very fortunate to be at OHSU. We have about 36 native faculty in the School of Medicine, 150 learners, native learners, between our med school, residency, fellowship, pharmacy, nursing. So we have lots of natives, and OHSU is very progressive in their views of our research. And although they haven't until this year financially support us, right now they are paying for Tori Eaglestaff to be our tribal research liaison. They haven't stood in our way. We've had some crazy ideas and they were okay with it, like the basketball tournament. So I think, you know, we've advocated for Indigenous knowledge. Our icon, our navigator, is not a trained navigator. She's from the community. She has community knowledge. And we advocated for that community knowledge being as important as a degree. And it's shown out to be true. She's been so great working with the communities that way. So I think I 100% recognize it'd be much harder at a different institution, and I do feel fortunate. I am also building off of the shoulders of Eric Broad, who established NACOE and has been a real advocate for Native health at OHSU. So when I walk into a room with this conversation at OHSU, I'm not the first person to talk about it. He's been in there talking about it. Our other faculty members have been talking about it and advocating for rotations in the tribal communities where our residents have been advocating for electives, tribal health electives, have been advocating to increase the number of tribal members in our schools. So I don't think I did anything specifically, which I wish I could give advice that would help. It's really been the collective effort of our entire Native faculty.
I'm curious about your rocker model and how that intersects with like tribal IRB submissions and that type of thing.
Yeah, so in some cases, tribes in the Northwest do not have their own individual IRBs. They utilize the Northwest Portland Area Indian Health Board IRB. So the Rockers process is a supplement to the IRB. It's not a replacement for the IRB for most tribes. Some tribes would like it to be a replacement for the IRB, and that's their decision. Because they don't have models, they don't have enough, their own individual IRBs to review this types of research. Moving to the West Coast, what I've noticed is the tribes are much smaller. And they don't have the established, a lot of the tribes don't have the same established infrastructure for this type of research review. So we have had conversations with tribes where they're just like, yes, this is great. We have nothing in place to review these types of projects. So we're never trying to replace the IRB. We're trying to supplement it with a stopgap before it actually goes to the review. Yeah, yeah, exactly. And then some communities do want it to serve as the IRB along with the Northwest Portland area and Health Board.
Anyone else have questions? I have another question. I had a question about how you've gone into communities and maybe informed them about data sovereignty.
So I think when we're going to community, I think we as people have this idea of sovereignty already. So I don't know how we're informing them.
Sure, maybe that.
Yeah, but we're upholding tribal sovereignty. When we give our talks, we always mention tribal sovereignty up front. Recognizing that the tribe owns all of this data, the tribe owns these projects, and we would never share or talk about them unless they gave us permission. Like today, where I have permission from Warm Springs to give this lecture. So, we're really just trying to say, we understand tribal sovereignty. We don't want to do anything to step on your toes. We're only going to work with you if you want us here, basically. Thank you.